milligrams, and then the fourth week would of course be 2.4. And then fifth week will be given 3.0 milligrams per day for that whole week. Then you stay at that 3.0 for up to 16 weeks. And if after 16 weeks you don't get greater than a 4% reduction in weight, then it means your successor will not work in that patient, so you simply discontinue. So that's how it is administered for weight reduction. Avaglutide not really used a lot these days. You mainly see Victoza, Trulicity, and Ozempic used. And we mentioned the percent A1C reduction that you can get with each of these agents. The one that will give you the most is semaglutide, which can give up to 1.5% reduction in A1C. If you use Wegovy to reduce weight, that's the special formulation of semaglutide that is used for weight reduction. If you use that, then you'll be given your 2.4 milligrams subcutaneously. Okay, and that will be given on a weekly basis. The Ozempic is the one that is usually used just for the management of your diabetes, and it can use a range of 0.5 to 1 milligram administered on a weekly basis. Okay. I'm going to have the class rep always remind the class that all cell phones are to be turned off at the beginning of class. Okay? We don't want that disruption anymore. It's not professional. Okay? So if you have a second, turn off your cell phone now, so we don't have that incident again. Okay. And your Rybelsus, you can see anywhere from 3 milligrams to 7 milligrams being administered orally. So that is an oral formulation of semaglutide, and that can be given on a daily basis, and it is administered on an empty stomach. So we've talked about the indication for your incretin mimetics, type 2 DM, and you can, we've also talked about the adverse effects of this group, which can be things like nausea, vomiting, diarrhea, dyspepsia, headache, possible urticaria, that is hives, and then you may have damage to the thyroid. The thyroid gland. Even though that has not been seen in humans, you can see it damage to the so-called C cells of the thyroid gland, which are actually, which would be like a tumor of the C cells. And C there stands for calcitonin. So you're talking about calcitonin producing cells of the thyroid gland. All right. So those will be your incretin that are administered parenterally. And now we go to what we really wanted to focus on, and that gland, the pancreas. And that will be insulin. We can start with the sources of insulin, where you get it. You can get it from beef, you can get it from pork, and of course from humans, come through recombinant DNA technology. Okay. And pork, of course, is a lot closer to human insulin than beef. For beef, the changes or the differences are found on your position 8, that is the amino acids. Let's put it this way. If you look at your insulin, you have your A chain and your B chain, and you have a connective chain which is called the C chain. And that the C chain was usually responsible for allergies to insulin. And since that has been removed through your recombinant DNA technology, you seldom see a lot of allergies to insulin. You have a total of, say, 21 amino acids on your A chain, and you have about 31 amino acids on your B chain. So you have a total of 52 amino acids on your insulin. The A chain is referred to as the acidic chain, and the B chain is the basic chain for your insulin. So the positions 8 and 10 will be on the A chain, and the position 12 will be on the B chain. If you, for instance, look at your beef insulin, that's what you will have at the 8, 10, and 30. If you look at the pork, you will see your threonine and your isoleucine, and then you can see some allergen there. And if you look at humans, you will have threonine, and you have isoleucine, and you have threonine for humans. So that's why we say that pork is closer to humans, because it is the same. The only difference will be at the 30 position on your chain of amino acids. Okay. So those are the sources of your insulins, and then of course you have some synthetic ones or semi-synthetic that you can see. For instance, if you look at your B chain, at the 28th position you have a proline, 29 you have a lysine. That's normal for your B chain. But if you switch these around, so that you now put lysine on 28 and you put proline on 29, what you will have there referring to that chain then, that change is Lispro. That's how you have your insulin Lispro, which is your Humalog. Okay, so it's just an interchange at the 28, 29 position. And if, for instance, you you put, instead of proline here, the 28 position, if you put aspartic acid to replace proline, then you have your insulin aspart, okay, which will be your Novolog. Okay. And it's the same thing for your insulin glucolysin. Okay. For insulin glucolysin, the position 3 on your B chain, if you replace that valine with lysine, okay, and the lysine here on 29, if you put in there glutamic acid, then you will have glue lysine. So that's how you get your insulin glycine. And so on. If you look at Lantus or insulin glycine, basically what you're doing is at your A chain, you will put glycine to replace that asparagine, which is the normal amino acid at the 21 position. And then at the end of your B chain, you simply add 2 molecules of arginine. Okay. And so you see your glycine and arginine. That's a very long acting insulin glycine, which is your Lantus. So just some minor changes in your chains of amino acids will give you some of those synthetic agents. So that's what we have for the sources of insulin. Now, how does insulin work? The mechanism of action of insulin. Normally you have, let's say, your blood vessels here. Okay. And then you have some cells in the body, like that. Okay. In the blood vessel, you have, let's say, your sugar molecules. And what insulin does is basically to internalize your plasma glucose. In other words, insulin tries to move sugar out of the bloodstream, into cells. Okay, internalization of your plasma glucose. And if you move the sugar out, then the blood sugar level will drop. So that's what the result would be. And so the question then is how? Because when you're talking about mechanism of action, you're answering the question how. Okay? So what insulin does is it will bind to the tyrosine kinase. So it binds to its subtype of tyrosine kinase receptor. And when it does that, you will get an autophosphorylation. Autophosphorylation of the insulin receptor substrate, or IRS. And the autophosphorylation of that IRS will activate your GLUT4, which is a glucose transporter. So glucose transporter 4, and then you will get the movement of glucose into the cells. So that's how insulin works in that regard. That autophosphorylation of IRS would also cause the movement of certain other things into cells. For instance, you will see the movement of electrolytes like potassium, like magnesium, like phosphate. Okay, those would move into cells. You also see an increase in the movement of amino acids into cells. So the amino acids will then lead to protein synthesis. Fatty acids would also move into cells, and so you will get an increase in lipid formation, so lipogenesis. Okay. And you would also see, of course, the formation of glycogen, because when you're internalizing glucose, glucose will be stored in the form of glycogen. Okay. So all of this one can see by that simple autophosphorylation of IRS. Apart from that autophosphorylation, you would also see the phosphorylation of other kinases. For instance, growth factor receptor binding protein 2. Growth factor receptor binding protein 2 would also be phosphorylated. And in this situation, phosphorylation is synonymous with activation. That is, you're activating those kinases. Okay. MAPK, that is mitogen activated protein kinase. Then protein kinase B, that would also be phosphorylated or activated. And then PIK3, P13K, phosphatidyl inositol 3 kinase. Phosphatidyl inositol 3 kinase. So all those kinases will be activated once insulin binds to that tyrosine kinase receptor. So once this binding occurs, you get autophosphorylation of IRS, and you get activation or phosphorylation of these other kinases. And what will all these other kinases do once they are activated? If you look, for instance, at MAPK, that is mitogen activated protein kinase, that always increases cellular growth. So with insulin, you can get an increase in cellular growth, and you can also get an increase in differentiation. Okay. And if you're talking about cells, and you mentioned the word differentiation, basically what it means is function. Okay. So you get increased cellular growth, you get an increase in cellular function, and then you will get an inhibition of the breakdown of lipids. So this get an inhibition of lipolysis, and you get an inhibition of gluconeogenesis, and you also get an inhibition of glycogenolysis. Okay. So all of those can result from the activation of these kinases. Okay, and if you go back and look at what we said about glucagon, you will see that glucagon does the opposite of this, glycolysis and gluconeogenesis and glycogenolysis. All right, so that's essentially how insulin works. The mechanism of action. So we've seen the source of insulin or sources, the MOA, and we can go to the ADME of insulin. Okay. And before we get to the ADME, because the ADME can also affect the classification of insulins. You can classify insulins based on the onset of action or based on the duration of action. Okay, and based on those two parameters, you can classify your insulins into those that are ultra rapid, that is ultra rapid acting insulins, and then those that are rapid acting, and then those that are short acting, and the ones that are intermediate, and then of course the ones that are long acting. So those are the classes of your insulin. And like I said, you can use either duration of action or onset of action for the classification. This is a relatively new classification or class, if you will, your ultra rapid. So if you just look at this lower four, you've taken duration of action, for instance. Your rapid acting agents would, usually start within, let's say, we'll have the duration of action of say 2 hours. The onset of action will be anywhere from 0 to about 15 minutes. Okay. So that would be like onset. So the duration of action will be like 2 to 4 hours. And if we look at your short-acting agents, the duration of action will be about 6 to 8 hours. Then your intermediate can be somewhere around 16 to 24 hours. And then long-acting will be greater than 24 hours. For instance, that Tresiba is about 42 hours in terms of its duration of action, so extremely long acting. So the ones that are ultra rapid will basically be like the rapid, but they will even be faster in terms of the absorption. Okay. So some examples of your ultra rapid agents would be the inhaled insulin, like your Afrezza. Afrezza will be ultra rapid. Exuberant will be an ultra rapid acting agent. Those two are administered by inhalation. Okay. And basically what happens there is you give about 4 to 8 units of these inhalation agents using a steamboat device. And when you inhale that powder, which is already formulated into like a little capsule. That powder is pH sensitive. And the medium, that is the lung medium, the lungs, is pH neutral. So when the pH sensitive powder comes into contact or gets into a pH neutral environment, its formulation, that is its physical formulation, changes because it is pH sensitive. So it now transforms a powder form into a liquid form. And that's what is absorbed through your alveoli and blood vessels there. So that's how those work. Actually, Exubera came before Afrezza, but the company had to remove Exubera, not because it didn't work. It was because they didn't have enough patients to put on it way back then.
Is Exubera on the market?
It's what?
Is Exubera on the market? Is Exubera?
Yeah, they removed it at one time, you know, because they were not making money. So it was an economic decision, you know. And when Afrezza came, then they also put it back on. So that's those are some rapid acting agents. And you have Viajet, which is actually administered by, administered parenterally. And that is a rapidly acting agent. Now there's one called Fiasp, which is, if you break it down like that, it is a fast-acting insulin aspartate or aspart. Okay, so it's even a more rapidly acting agent than your, insulin aspart. It gets absorbed into the body within, in less than 2 minutes. So those are your rapidly acting agents. There's one thing, well, two things that is common to those ultra rapid acting agents. Number one, they produce less weight gain compared to all these other insulin. Insulin tends to increase weight. Okay. Remember we mentioned your incretin mimetics reduce weight. So insulins increase weight. But you will get less weight increase with these ultra rapid acting agents. And they also tend to produce less hypoglycemia than all these other insulins. So those are two positive things that you see with your ultra rapid acting agents. And of course you have your other classes. So ones that are rapid acting agents would be like your Humalog, Novolog, and Apidra. So and of course you have a derivative of your Humalog, which is your Admelog. Admelog is not a generic form of Humalog. It is a biosimilar formulation of Humalog. That's a difference. A biosimilar drug is not a generic formulation. You cannot have a generic formulation of a biological acting agent like insulin that is large in terms of molecule size. Okay. When you use the word genetic, it means pound for pound, what you're producing as a generic formulation has to be exactly the same thing as the brand. You can get that done with smaller molecules. It's impossible to get that done with large biological molecules. And so you just say that they are biologically similar, but they are really not exact, so we can't say they're generic formulations. Okay. You have that Esagla, which is a biosimilar form of your Lantus. It is not a generic form of Lantus. It is a biosimilar form of Lantus, just like Admelog is a biosimilar form of your Humalog. But in a way, Admelog is even faster absorbed than your normal Humalog. So it can start acting a little bit faster than your Humalog. So those are your rapid acting agents. And you have the examples of short acting agents. Short acting agents will be your regular insulin. So if you're talking about Humulin R, Aminobumin R, those are your short acting agents. And you see the difference in terms of duration. You can also see the difference in terms of onset of action. Okay. The intermediate acting agents would include your NPH, that is the neutral protamine hydrodrone. And N is neutral protamine hydrodrone. That's the insulin that is also sometimes referred to as your isofen insulin suspension.
Question. Those agents, they are short acting or intermediate?
Which one?
Those agents you just mentioned, Adebron and.
You're talking about your NPH, you said?
So the NPH is short and.
No,
Adebron
NPH
is-
will get into
Intermediate.
intermediate acting agents.
Okay. Okay.
Short will be regular. See?
Oh, regular on, okay.
Yeah. Okay. So the NPH will be your intermediate acting agents, and the NPH, like we said, is neutral protamine and protamine. Okay, that is a fish protein. And where else did you come across protamine? Protamine sulfate? Okay. And what would you be most concerned with when you use protamine sulfate? It will cause severe vasodilation, blood pressure will drop rapidly. Okay. But anytime you have protamine in terms of insulin, protamine tends to increase the duration of action of that insulin. Okay. For instance, if you add protamine to insulin aspart or even to lispro, you get that combination moving into intermediate from just rapid. Okay. So you have those, then you have your different examples, like Prozac, protamine, zinc. Okay. That would also be an intermediate agent. And if you see insulin lente, that would be intermediate acting. Okay. And the lente also has some zinc, so it is your insulin zinc suspension. That's your lente insulin. Now, if we look at the long-acting agents, we mentioned one of them, insulin glargine, like your Lantus. And then you have your detamere, which would also be long-acting, and you can have ultra-lente. So those ones would be long-acting, and the Tresiba, or insulin degludec, which will also be a very long-acting agent. So those are your different classifications of insulin. If you if you look at the insulins, usually they come in terms of concentration. Say 100 units per mil for most of them. Because some are different. That Prozac, for instance, Prozac is a 40 units per mil preparation. Okay. If you look at Toujeo, that's 300 units per mil preparation. Each pen contains 450 units because each pen contains 1.5 mil. So 300 per mil will give you 450 units in each pen of Toujeo. Okay. So you can have different ones like that. Tresiba, you can have 100 units per mil, and there's also 200 units per mil of Tresiba, the extremely long-acting agent there. And then you can see one that is actually 500 units per mil. Okay. 500 units per mil of your insulin is the one that you would use to treat, let's say, diabetic coma. So where you need a high dose of insulin, to basically try and revive that individual.
What did you call that drug?
What?
What did you call it? You called it a pen?
No, the pen, I used the pen when we were talking about
Toujeo? And you use that in diabetic coma?
Yeah, diabetic coma. You can also use it in the DKA patient, diabetic ketoacidosis. Okay, so those are your different classifications or formulations of insulin.
Dr. Mo, what about the combination, like the 70-30s, the 70-25s, 50-50s? What are those fall under?
Okay. Anytime you see a combination of your insulins, the numerator is usually the longer acting agent. The denominator is the shorter acting agent. So for instance, if you see 70-30, if you're talking about, let's say, hemoglobin, okay, the 70 is an intermediate acting agent, like your NPH. And then the 30 will be the shorter acting agent, which could be your regular insulin. So the numerator is always the longer acting one in that agent. You can have 70-30, you can have 75-25, you can have 50-50, so there are different preparations like that, but the upper part is always the longer acting agent. There's a product called Razodate. Razodate is a combination of Tresiba and Aspart. Okay. And you will have it, say 70-30 preparation, so that the upper part will be your Tresiba and the lower part, that is the denominator, will be your insulin Aspart. Even if you have protamine insulin lispro, for instance, you can have it in combination with your insulin lispro, 70-30. Because of this protamine, this part here becomes an intermediate acting agent. So it is longer acting than the shorter one, which is just your regular hemoglobin. Okay. And in terms of A1C reduction, your insulin preparations can give you anywhere from 1 to 2%. So they're very good in terms of A1C reduction. Okay. So those are your different preparations. We looked at the source, we looked at the mechanism of action, we looked at the classifications, and then the ADME of insulin. With ADME, we always start off with the routes of administration. You can give insulin subcutaneously, IV, and IM, especially if you're thinking about your regular insulin. Okay. For maintenance purposes, the subcutaneous route is what is used, subcutaneous. You can see regular insulin given IV or IM when you need a rapid reduction in plasma glucose, like when a patient is in a coma, if they have that diabetic ketoacidosis. ketosis coma, for instance. You can see rapid, that is, IV or administration of your regular insulin during gestation or labor and delivery. So you may need the rapid action of insulin there, so you give it intravenously or intramuscularly. And you can see this route used when you are doing a surgery, or what we call peri-surgical situations. So you're doing surgery and all of a sudden you see plasma glucose rising, you need to bring it down rapidly. So you give your insulin that way. And of course, we talked about the other preparations that can be administered. Now, inhalation, Alphaza and Zupra can be administered by inhalation. And if you're looking at the administration of insulin, it is best absorbed from your abdomen. We're talking about subcutaneous administration, and that will be greater than from your upper arms, which will be greater than from your quads, that is quadriceps, okay, which will be, of course, greater than your gluteus maximus, or on the buttocks. And if you apply heat, or if you rub, or if you increase perfusion through exercise, okay, then you can see an increase in the absorption of your insulin from the site of administration. Okay. And you want to rotate the site of administration such that you don't get within 1 inch, not closer than 1 inch of any site per month. Okay. The reason for that is because you want to prevent what is called lipodystrophy. And lipodystrophy is normally regarded as an adverse effect of insulin. So we'll discuss lipodystrophy under the adverse effects. But you want to change the site of administration. You want to be within 1 inch of the previous site in 1 month. And so that's in terms of the routes of administration of your insulin. And there are ways that you can deliver your insulin. There are different ways of insulin delivery. We mentioned one of them, the pre-filled pens. Some actually still use the cartridges. So, and then you have some that you still have to draw up from the vials. Okay. And you can use what is called a sliding scale, which is not very popular today. Sliding scale of insulin delivery. In that situation, you look at what the plasma level of glucose is. If it's less than 140 milligrams per deciliter, you don't need to administer the insulin. usually use short-acting insulin for sliding scale. Okay. If it's between 140 and 200, you administer 2 units of insulin. Okay. If it's between 201 to 300, you can use 5 units of insulin. Okay. And if it's between 301 and 400, you administer 10 units of regular insulin. And if it's greater than 400, you use 12 units of insulin. So the sliding scale is delivered or is used through a pump that is attached to the patient. So that's another delivery method for insulin. And then you have your continuous subcutaneous insulin infusion. Continuous subcutaneous insulin infusion. And that also basically uses a pump. Okay.
Like people who have the insulin, like I guess monitor, that's the pump.
That's that. Okay. And you have different types. Just one example is your Tandem, or Tandem T. It's a pump that will continuously give insulin subcutaneously. Okay, there's another one called patch. So you have different forms. NovoPen is another one. It's called NovoPen Echo. So these are different CSII pumps.
And do the pumps, do they work in a consistent dosage, or do they work in a sliding scale method where it monitors the glucose and correlates the dose based on that?
No, they will not work through sliding scale.
Okay.
They deliver a certain amount that you can adjust.
Okay.
Yeah, you can adjust. And they are always combined with what you call a continuous glucose monitoring device, like Dexcom. There's a program called Dexcom G6. Okay, it's a monitoring device. Okay, so you have the pump delivering the insulin, and then you have the monitoring device that is monitoring the glucose. It's a continuous glucose monitoring, levels. So you can then adjust your pump based on what the result is there. Okay. Of course, you have a delivery system that you can call bolus basal system. Okay. You give a long-acting insulin or an intermediate-acting insulin that will cover 12 to 24 hours. Okay. And then, see, if you give your, say, Lantus, it will cover up to 24 hours like that. And then at the time of a meal, when you eat breakfast, lunch, dinner, you will give a short-acting one, to just take care of the increase in glucose postprandially, that is after the meal. Okay, so the basal will be the long-acting one, long-acting of intermediate. If you use intermediate, it will cover up to 12 hours. If you use long-acting, it will cover up to 24 hours. And then by the time of eating, you give one bolus short of your short-acting or rapid-acting insulin. You have a jet stream that can actually deliver insulin without using a puncture. Okay. That's one example called Insujet. There's another one you can see, a Cityjet. So that does not use a needle as such. So you can get your insulin into the body fast. So those are some delivery systems for your insulin. The metabolism of insulin, that's mainly through tidal metroprotein. So that can metabolize your insulin, because you know insulin has amino acids, which means a protein, because those are the building blocks of the protein, and so the proteins can break it down. And you have some carboxypeptidases in the body. See, the thiometroproteinase works mainly in the liver, but insulin can be present in other tissues, like your lipid, that is your adipose tissues, for instance, your muscles, for instance, and the carboxypeptidases that are present in those tissues can metabolize your insulin. The movement of insulin into cells, the movement of sugar, glucose into cells by insulin occurs in every cell in your body, with the exception of two. You don't need insulin to move sugar into your red blood cells. And you don't need insulin to move sugar into your brain cells. Those are the only two. All other cells in the body require insulin for internalization of glucose, but not your red blood cells, and not your brain cells. Okay? So basically we're at the metabolism right there. In terms of excretion, well, let's say something about distribution here. Insulin has a negligible, almost zero plasma protein binding. It does not really bind to protein. So it's like a 0 to 9% plasma protein binding for your insulin. And of course, once it's metabolized like that, you can get renal excretion of your biotransformed insulin. Okay, so that takes care of your acne, and you look at indications for insulin. So what do you use insulin for? One will be your type 1 diabetes mellitus. Another will be your type 2 diabetes. And then the other one will be your gestational diabetes mellitus. That is diabetes that is associated with pregnancy. So gestational diabetes mellitus. And if you have a high level of potassium in the bloodstream, hyperkalemia, remember when we were talking about mechanism of action of insulin, we said it can internalize certain electrolytes, one of them being potassium. The relationship between insulin and potassium is actually very funny. If you have a low level of extracellular potassium, if your extracellular concentration is low, you would actually see a decrease in the function of insulin, which means plasma glucose will go up. Okay. That's why patients who have been on a thiazide for a long period of time will eventually develop hyperglycemia and maybe even diabetes, because your thiazides will deplete your potassium, and if that happens, you get a decrease in the functionality of your insulin. So protracted use of thiazides, and of course your high ceiling diuretics, Lasix, can eventually exacerbate diabetes or even produce diabetes.
Taking a potassium supplement kind of negate that, or is it just?
Yes, it can.
Okay.
It can. But even with you advising the patient to drink a glass of orange juice or eat one banana or give your K-tab and all that, if the patient is going to stay on hydrochlorothiazide for a long time, you can still get a decrease in insulin function, which means plasma glucose will go up. Even though DKA is an adverse effect of insulin, it is also one of the indications of insulin. So, diabetic ketoacidosis, you can use insulin for the management. And I would also put HANX in there as one of those. That is your hyperosmolar hyperglycemic non-ketotic syndrome. Okay. So you have hyper, that is the osmolarity of the body is high, glucose level is high, but you don't have ketone bodies, non-ketotic syndrome. And for DKA and HANX, you use a very low dose of insulin. You give about 0.1 unit per kilogram of body weight per hour. So it's just infused, until the patient comes out of a coma, because DKA can also lead to a coma. So those are your indications for insulin. And what are the adverse effects of insulin? One, you can have hypoglycemia. That's possible adverse effect of insulin. And the manifestations can be of an autonomic nature or what we call a neuroglycemic nature. The manifestations of hypoglycemia caused by insulin can be characterized by things like, tremors and anxiety, and of course hunger. present there. Orestesias, that would be like sort of needles and pins sensation. And that you say palpitations, which may actually be representative of tachycardia or an increase in heart rate. And then, of course, they can have sweat. All of those are referred to as the autonomic manifestations of insulin-induced hypoglycemia. Okay. The ones that are neuroglycopenic, let's see what they are, neuroglycopenic manifestations. Those have to do more with central nervous system. So the patient can't concentrate. Okay. And you will know that when you look at their scores in pharmacology. Okay, so they cannot concentrate. You can have, you guys are slow. Okay.
We're trying to be serious, man.
You're serious today.
Yeah. Or they can just lose concentration. Okay. And sometimes you can see a loss of consciousness. Okay. And then others will be things like dizziness and possible drowsiness that can happen with this. So the neuroglycopenic signs and symptoms of insulin-induced hypoglycemia are basically centrally related.
Would you mind explaining how low sugar makes you pass out?
It will depend on the individual.
Okay.
Yeah. Yes. Now, so that's one adverse effect. Then you can have what is referred to as insulin edema. Okay, and in that case, you will see bloating. That would be a manifestation. And of course, an increase in extracellular fluid, which is what you refer to as edema. So that can basically lead to increased weight. So the increase in weight that you see with insulin patients is more fluid related. Okay. So then you can have insulin resistance, and I will also put in there allergies. Those have decreased over the years because we now use, human sources. That is the insulin that we get from changing some of the basic amino acids in the human insulin. So that was a time back in the 60s and 70s when the doctors actually scared to give insulin to the patient because they were just falling on the chair, due to allergies. And once that C peptide was removed, you saw less of this resistance or allergy. This is the one that I say you can manage by using that 500 unit concentration of your insulin, the regular insulin. So you give that high dose to reduce that. And of course the allergy reduced because you were not using animal sources for your insulin. The edema, that fortunately just spontaneously reverses. So we really don't do much with that. Edema. Lipodystrophy that we mentioned earlier, still right there, lipodystrophy. It can be of two types. You can get lipoatrophy, and then you can get lipohypertrophy. So those are the two types. Atrophy, of course, will mean that you are seeing a breakdown of fatty tissue at the site of injection. That's why you don't want to use the same site too often. That's why we said, no more than 1 inch from the site of administration, at least within 1 month. So that will be lipoatrophy. Lipohypertrophy will be the opposite. You will see an accumulation of fatty tissue at that site of injection. Okay. So that's lipohypertrophy. You have a drug that is called myelin that is actually used to treat insulin-induced lipodystrophy. So it's a very effective agent there. Okay. And then you can have, like we mentioned earlier, diabetic ketoacidosis, DKA, as an adverse effect of your insulin. Okay. So, those are the adverse effects. Because that's what we have for your insulins. And that takes us to the end of the parenterally administered drugs for your diabetes. We can now switch gear to agents that you will give orally for the management of diabetes. And there are many classes of drugs that you can use. We can start off with your DPP-4 inhibitors. Okay, that 30 days for inhibitors. And some examples there are your sitagliptin. So these are the ones that are called the gliptins. Okay. And you have saxagliptin. Okay. You have valdagliptin. And you have your alogliptin. And of course you have your linagliptin. These agents, and very often be used in combination with other agents So, you should find out what you have in Grizambi, what you have in combi guys. What do you have in Casano? What's present in Hosseini? And what's in Galsmet? Okay. What do you have in Janomet? What do you have in Gentile well? Okay. Okay. So for that class, what's the mechanism of action? The mechanism of action is a classification, inhibition of DPP4. You inhibit DPP4, you increase incretin magnetic level or incretins level. They go to the beta cells, they stimulate insulin production. Insulin reduces plasma glucose. So that's how they work. The other aspect of their mechanism of action is that they can actually decrease glucagon production. Okay, so it's not just inhibiting DPP4, they can also decrease glucagon secretion. And if you decrease glucagon, then you will be decreasing the likelihood of getting hyperglycemia. So that's how they work. Okay. Don't think that DPP4 is the only DPP that's available in the body. Okay. You also have DPP8 and DPP9. It's just that those are not related to your glucose metabolism. So that's the mechanism of action, and we'll take linagliptin as the representative agent for this group. So its mechanism of action will be the same for all those drugs. And we can look at its admin. Linagliptin is administered orally. So the pill, food does not affect the kinetics of your linagliptin. Okay? So you can give it with or without food. That's what we said here. In terms of its plasma protein binding, it can go anywhere from 79% to 99%, and that is concentration dependent. In other words, it is a saturable process. The greater the amount of linagliptin you give, the more of it will become plasma protein bound. So it's saturated. And why we would be interested in PPB, plasma protein binding, of course, can give you an idea of drug-to-drug interactions. Okay, that's one. Plasma protein binding can give you an idea of how easily that drug can penetrate the blood-brain barrier, which means it can invariably give you an idea of whether the drug will have CNS side effects or not. So that's why you want to have an idea of the plasma protein binding of a drug. Okay. So if we look at the half-life, The half-life for linagliptin is 131 hours. What's the interest in half-life? Half-life can give you an idea of the dosing of that drug. If the drug has a half-life of 131 hours, you can only administer it one way. It has to be QD. Okay. So half-life can give you an idea of the frequency of administration of a drug. And so, in this case, in the case of linagliptin, you usually see that dosage, 5 milligrams PO QD. That's what you would normally use. And then if we look at the metabolism, about 90% of the administered dose would actually be excreted unchanged. Okay. A little bit of it can be metabolized by cytochrome P453A4. Just a tiny bit of it. And how do we know that a part of that drug can be metabolized by 3A4? It's because if you give a 3A4 stimulant, that is a drug that will stimulate that cytochrome P450 system, you will actually see a decrease in the effectiveness of your linagliptin. Okay. Now, linagliptin itself can cause a minimal inhibition of your 3A4. So it can give you a minimal inhibition of cytochrome P450 3A4. In terms of the excretion, it is mostly through the enterohepatic pathway. About 80% of the administered dosage would be excreted through the enterohepatic system. A very, very small amount, just about 5%, can actually be excreted through the urine. So what does that tell you? Renal dysfunction does not affect the kinetics of linagliptin. So if the patient has renal dysfunction, you can still use linagliptin because only a tiny amount will be affected, in terms of urinary excretion. Indications for linagliptin is mainly used in your type 2, and we've seen the dosage. And when you look at some of those combinations, you can see that it can work alongside with some other agents. Okay. Now, the adverse effects of linagliptin. One is it can produce hypoglycemia. The chances of linagliptin causing hypoglycemia will be increased if you were to give it concurrently with an SU, that is sulfonylurea. So if you give it concurrently with the sulfonylurea, you will see an increased chance of it producing hypoglycemia. And that is true with all of your incretin-mimetics also. Because you look at the actions of this drug, it's basically incretin-mimetic in nature. you would save in ratings. So if you give it concurrently with sulfonylurea, or if you give it concurrently with insulin, you will see an increase in the chances of getting your hypoglycemia. 2, nasopharyngitis. Okay. Nasopharyngitis is another adverse effect of that drug. And 3, it can cause pain. You can have arthralgia, myalgia, so pain in the joints, pain in the muscles, and it can also give you pain in the back or back pain. So it does produce pain, basically. Okay, put all of those up there. To some extent, it can actually also cause an inflammation within the pancreas. So pancreatitis is a possible adverse effect of your liver. A1C reduction, it falls within the range for your other incretin-mimetics. So you can say it give you between 0.7 and 0.8% reduction in A1C. Okay. So that's your DPP-4 inhibitors, and we'll just use the last 5 minutes to look at your SGLT2 inhibitors. So that will be another class of orally administered anti-diabetic agents. So this will be the agents that would inhibit the sodium glucose cotransporter 2, particularly at the renal level. So if we look at your kidneys this way, here, you have your glomerulus over there, and all that. So you can have some of your sugar or glucose in the renal tubule, like that. That glucose is sometimes supposed to be reabsorbed into the bloodstream. And one of the transporters that will do that is your sodium glucose cotransporter 2. So some of the drugs that belong to this class would include dapagliflozin, and of course they are all gliflozins. So you can have canagliflozin, like that. Empagliflozin, and you have orthogliflozin. Okay. And the one that we'll take as a representative agent there is canagliflozin. Dapagliflozin actually went to the FDA before cannabis crossing, but the application was initially rejected because it was found to produce too much of a risk of breast cancer and bladder cancer. So it was rejected, and that's when cannabis crossing came on the market, and the company went back and reformulated their cannabis crossing such that you have less risk of breast and bladder cancer. So these are basically the 4 SGLT2 inhibitors. Taking cannabis as the prototype or the representative ingredient, we look at its mechanism of action, which is basically that. It inhibits the movement of glucose back into the bloodstream, so you now have a lot of glucose going out in the urine. Okay. And so plasma levels of glucose will drop. So that's the mechanism of action. We look at ADME or cannabifrosin. We know it is administered orally. Okay. And when it is given, the dosage is usually 100 to 300 milligrams QD. And you want to give it just before the first major meal of the day. Okay, so it has to be given before the first major meal of the day. If we look at its plasma protein binding, it's very high, that is greater than 90% in terms of plasma protein binding. So you would expect it to cause little or no CNS related adverse effects. Okay. The half-life for the drug is about 11 to 13 hours, close enough to permit a once-a-day administration. So it's usually administered on a QD basis. Okay. In terms of its biotransformation, there's nothing to speak of there. So in other words, the cells are biotransformed, and then the excretion is more in feces than in the renal system. And so it does go out in the urine, but it's more in the feces than in the renal system. Indication, of course, will be your type 2. That is A1C reduction that it gives you is about 0.93% A1C reduction. So it's very good, close to 1. Okay, so that will be the indication. And this is another drug, well, this SGLT2 inhibitors can be used in combination with other agents. And we'll mention a few of them later. Now, in terms of the adverse effects of cannabifrosin, you can actually derive the adverse effects of cannabifrosin from its mechanism of action. So, if you're losing a lot of glucose, wherever glucose goes, water follows. Okay? So, you'll see an increase in glucose excretion, which basically means that you will see an increase in urination. water follows the glucose. Okay? If you have an increase in urination, what can happen is that you lose body volume, okay? Because water is going up with glucose. You decrease extracellular fluid volume, you can see a decrease in blood pressure. You decrease extracellular fluid volume, you can see a decrease in weight. Okay? And the loss of water can lead to dehydration. And if you have dehydration, your senses are affected. So you can see, dizziness, and your skin becomes dry, so all of those can be based on that dehydration that you will see. And because of its effect in terms of affecting the exchange of glucose and sodium, you can actually see an increase in potassium level. If you see an increase in potassium level, that can affect the cardiac tissue. Okay? So you can actually see the increase in risk of your chronic cardiac failure. So chronic cardiac failure increase the rate, and you're affecting electrolyte balance. So the electrolyte imbalance can lead to a risk of your bone density. So all of those really you can derive from the mechanism of action of that drug. And the other adverse effects that we know, it can produce DKA, diabetes ketoacidosis. It is nephrotoxic. It is also hepatotoxic. And because of the effect on bone density, you can see an increase in bone fractures. So one can see a lot of those things. Some people are hypersensitive to the drug. So hypersensitivity is an adverse effect of your canagliflozin.
What about UTIs? What about UTIs?
Yes, we're coming up with that. We have to give a reason for it. Okay. So that was all fluid. What about the glucose? Whenever you have an increase in glucose in the body, bacteria can grow because bacteria love glucose. Okay. And I used plural. I didn't say bacteria loves. Okay. Because that is the singular for bacteria. Don't say bacteria does something. Bacteria is plural. Okay, bacterium is singular. Okay? So bacteria, that's plural, they love glucose. And since you have a lot of glucose now in the urinary tract system, bacteria can grow And so you can have an increase in urinary tract infections because of the bacterial growth. Okay,
One question, so can you say that any medication that increases the excretion, like as far as the water glucose follows theory, will cause a UTI?
it depends on how much sugar that is.
That is in that
is
person's
in
body?
in that environment,
Okay.
yes.
So if a person has a high sugar content in their body, but not, let's say they're pre-diabetic but not diabetes,
Not that.
they're prone to UTIs?
Right.
Okay.
You know, and that's why you say one of the prominent manifestations of diabetes is vaginal infection. Because you have a lot of sugar that's available for bacteria to grow. You know. Maybe we'll leave that for another class, or maybe you've done it. If you look at the signs and symptoms of diabetes, you can actually classify them into only two. Those that are developed or those that are a result of lack of insulin, and those that are a result of too much sugar in the bloodstream. If you look at those two, you can very easily describe a picture of diabetes. Now, for instance, how do you get ketones? Why is ketoacidosis a possible manifestation of diabetes? So you haven't done it, okay.
We're waiting for you.
So we can hold it here for the orally active agents, and I think in your handout you'll see some combination drugs that we put here. For instance, if we say Synjardy will be empagliflozin plus metformin. Okay. And the newest one is Trijardy. Trijardy uses empagliflozin and metformin, and then linagliptin. So Trijardy is 3 drugs in one. Okay. Linagliptin, which means it contains a DPP-4 inhibitor. Okay. Empagliflozin, which means it contains an SGLT2 inhibitor, and then metformin, which of course we will discuss later. It's usually the first drug you start a diabetic patient on. So those are what we have. Questions?